Well, first of all, welcome to the Wellness and Lifestyle Medicine Symposium. I am Amit Gudigoli, the current president of the Texas Indo-American Physician Society, the Northeast chapter, the TIPS NEC president. And I would like to personally welcome each and every one of you and thank you all for being here on a Saturday morning. We have about 200 attendees, so this is already a great success. It shows how much interest there is in this topic. So give yourselves a big round of applause. This is the 14th CLE that TIPS NEC is conducting. And this is the first one we are having on wellness and lifestyle medicine. And also the first one we are partnering with County Medical Society. So we're very excited to be partnering with the Dallas County Medical Society. You know, the currency of health should be wellness and not treatment of illness. However, in the last several decades, the pendulum has swung to the right. So we've all become people who treat illnesses. And I, as a cardiac electrophysiologist, am the poster child for the current healthcare status. I put defibrillators in patients with prior heart attacks and cardiomyopathy and EF of 20%. So it's a little ironic that this symposium should occur when I am the president. However, this happened, it kind of happened all of a sudden, but last year I had no inkling that we would be here. I have to give credit to an inspiration I got from the last API. API is the American Association of Physicians of Indian Origin. So they had a convention in San Antonio last summer, and they had a wellness track, and I happened to sign up for that. And I have to say, the kind of lectures I heard there from these absolutely awesome people, who are not only great speakers, who not only have great content, but it's their life's mission to spread the word of wellness and lifestyle medicine. So, and I have to give a shout out to Dr. Ravi Kohli, the current president of API, who's been kind enough, he flew in from Pittsburgh to be here. So thank you, Ravi. So, when I got back to Dallas, I said, we got to do something and spread this word to bring this to our physicians, our TIPS members and the larger physician community. So the first thing I did was I called our very own Dean Ornish, our very own wellness guru, Dr. Anup Kumar Shetty. As many of you know, he has conducted several symposiums like this on wellness and given talks. So he and I sat together and came up with this vision. But of course, a vision without execution is an illusion, as they say. So there are many people behind this, and I would like to take 30 seconds to thank a few of those. Of course, the first is our CME chairs, Dr. Anup Kumar Shetty and Dr. Winnie Bapna. Dr. Bapna couldn't be here. She had to go back to India to attend to something, but everything's all right. She's here in spirit and she sends her best wishes. I also have to thank our CME committee, who is so dedicated and came up with great ideas, great suggestions, and of course our board, the TIPS NEC 2023 Board of Officers. And special thanks to the Dallas County Medical Society, Dr. Donna Casey, the president, and John Roth, the CEO. And they were excited to partner with us, and they helped promote the event. They've been great partners. I also need to thank our sponsors, without whom some of these things would not have been possible. The main platinum sponsors have been IntraCare, AstraZeneca, and Novo Nordisk. We do have a lunch talk by IntraCare and 2 product theater talks during lunch by AstraZeneca and Novo Nordisk, so please attend them. Of course, these are our other sponsors. We got to take care of this flashing. By the end of the evening, by the end of the day, people will be dizzy if they continues.
Darshan Mehta is another wellness guru. He's an assistant professor in medicine and psychiatry at Harvard Medical School and Harvard Hospital. He's a medical director of the Benson Henry Institute for Mind Body Medicine at Mass General Hospital. He's the director of the Office for Well-Being with the Center for Faculty Development at again Mass General Hospital. He's an internal medicine and integrative medicine consultant to the home-based military program at Mass General. In addition, he is the Mass General site director for the practice of medicine. He also is an educator. He develops curriculum required for the first year medical students at Harvard Medical School and leads their well-being curriculum. There is some more stuff, but he actually is a product of UT Southwestern, so this is homecoming for him. And he has spoken to us a few times in the past. And welcome back, Darshan. And his topic is going to be the Wounded Healer, Understanding Our Journeys in Health. Wounded Healer, Understanding Our Journeys in Health. Welcome back, Darshan.
Thank you, Anunti. It's really an honor to be back. I know there are people streaming in from the break. So hopefully everyone has their cup of coffee. You just got an extra 5 minutes of life as a result of it. But I hope you don't fall asleep. Okay. All right, I have no financial interests or relationship to disclose. So, all right, so what I hope to do in these next 40 minutes or so is to really take you through a journey. And this journey is actually going to be a personal journey. For me, I'm going to use, you'll see my own life as an example of understanding this concept of the wounded healer. And if there's one take-home point that I think the two previous speakers already have made very clearly, but I'll also reiterate, is that we are actually no different than the patients we serve. I think I have learned that with a tremendous amount of humility in my own life journey to understand also why I still want to not only just survive in this profession of medicine, but thrive in this profession of medicine. So I'm going to talk a little bit about just how we have our learning environments here, and we're all lifelong learners as physicians. That's why you're here today, as a learner. And how do we create these learning environments in medicine? A little bit about the epidemiology, the consequences. I'm going to share with you some experiments that we've done at Harvard Medical School and at Massachusetts General Hospital with our colleagues, physician colleagues, and just to give you a sense of what might be possible, that if we can do it in those hospitals, that maybe you can do it in your own practices as well. And then think about future directions. And then if we have time, depending on time, maybe even lead you to a brief experiential activity as well. So I just want to take a moment to pause. These two individuals. You may or may not recognize these two individuals. The person on the left, his name is Dr. Skip Atkins. He's a well-known primary care physician at Massachusetts General Hospital, worked in the community health center, was like the pillar of the community, very active in local politics, was the physician that all patients would just want to have, really was their advocate on all fronts. And on the right is Dr. Lorna Green. She was an emergency medicine physician at NYU in New York City, was one of the first frontline providers at the height of the pandemic in New York City to be right at their front line. What was common of both of these individuals is they're both beloved colleagues. They're both passionate individuals. They're dedicated to their profession of medicine in their respective fields and respective contexts. And what's also true about both of them is that both of them died by suicide. And so this is a story that is actually more common than you think. And this is well known. This is not, I'm not sharing it. It was publicized, and you can see in the New York Times. Top ER doctor who treats virus patients dies by suicide. This is her family. This is her sister and brother-in-law created a foundation which has actually had tremendous national legislative advocacy on really addressing clinician burnout, which is a real phenomenon. On the right, you'll see this beautiful article written by Skip Atkins' younger brother in the Annals of Internal Medicine. Put your oxygen mask on first. And one of the lines in this article, if you haven't read this brief essay, is really powerful. He says, "How could a doctor who meant so much to so many take his own life?" And then in the Washington Post, this is an article that was written by his colleague as well. So this is, we have this thing, sometimes some of us are faced into this situation, right? Really, it's quite all right. You see, at this clinic, we believe that only the wounded doctor can heal. So what is the wounded healer? And that's really the question. This actually is a concept that comes from Carl Jung, or it was made, I guess, more famous by Carl Jung. He talks about the archetype of the wounded healer. And if you think about your own reflection of how you entered into medicine, for some of us, it's we overcome the pain of our own suffering by becoming compassionate teachers and show others how they too can transcend their own pain. We transcend our suffering through the path of service, right? Many of us are service-oriented. That's why we entered this field, leading them to help others. We see this suffering in others, and they therefore can lead others to find ways to overcome their own suffering. And then, what is probably the most humbling part of this is that we may help heal wider ailments of humanity's shared life, but our wounds may not fully heal, and recognizing our own wounds in the process. And so, you see, there's different images here of the wounded healer. The upper right is actually this Greek figure, Chiron, who was in the Greek mythology was the quintessential healer and got wounded in a playful fight with Hercules. And the only way to transcend his pain was to let go of his immortality, to become mortal. And that's the story. There's David Carl Jung. I show this. It says, "One does not become enlightened by imagining figures of light, but by making the darkness conscious," as he describes the wounded healer. Radiologists really understand that well. And on the right, bottom right, is this is a picture of two figurines. These are from Japan. And this figure, you can see one is holding the hand of the other. But what you don't know about this, what this is actually meant, is that both of these are actually healers. So if you think in your own profession, how often have you been held by the hand of another colleague? Or how often have you held the hand of your colleague in your workplace? Is that a part of how you live at work? So I want to just give some operational definition, because some of these words are often used and we don't necessarily, we might be saying something. So this is the framework that I'm going to share with you. Again, there are different frameworks out there, but I just wanted to give you a sense of when I use certain words, what do I mean? So what is burnout? Burnout is a syndrome that is conceptualized as resulting from chronic workplace stress that has not been successfully managed. It is characterized by three dimensions: feelings of energy depletion or exhaustion, increased mental distance from one's job, or feelings of negativism or cynicism related to one's job, and reduced professional efficacy. Burnout refers specifically to phenomenon in the occupational context and should not be applied to describe experiences in other areas of life. So this is an occupational syndrome. Now it is sometimes very closely related to clinical syndromes, like if you want to name one, for example, depression. But this is really an occupational definition. So let me just as a show of hands, how many here either have known someone or yourself have faced burnout? Look around you, right? So this is amazing, right? So it's almost, we have 2/3 of the audience are raising their hands. And it tells you how common and prevalent this is. There is occupational stress, and these are harmful physical or emotional responses that occur when the requirements of the job do not match the capabilities, resources, or needs of the workers. And never did we feel this much more powerfully than these last 3 years, right? When for many of us, our demands were much higher. We had a sense of uncertainty, both here, when we think about all the different factors intrinsic to the job, poor physical working condition. We didn't even know what we were dealing with in the beginning, right? There was work overload, time pressures, physical danger, the role in the organization, who's doing what, right? And we saw this at all types of healthcare roles, right? So from the individuals who cleaned the rooms after the patient was either had passed away or discharged. And you could see like they were faced, like who's doing that? The role conflict, responsibilities. Then we think about promotion and career development. The relationships at work. When we spend, for many of us, 2/3 of our lived lives, our wake lives, at work, and if you don't get along with the people you work with, that's a difficult environment to be around. We have difficulty in delegating responsibility. Then the organizational structure. We've seen, some of you may be still in smaller practice environments, but many of us work in larger, sort of what I would call more corporate environments. And so there's these mergers and acquisitions happening, increased loss of control over schedules, autonomy, politics. So that affects us as individuals. There also is an extra organizational factor. So you think about where your children might be going to college, or you have other family problems, going through life changes, divorce, going through loss of family members, and then your own health conditions, right? And so this can actually contribute to one's own health conditions and health behaviors. So we know that during the pandemic, the increase in alcohol consumption was at least twofold, resulting, it can be attributed to at least a 7 to 10 pound weight gain that we see that happened over the past 3 years. And then other conditions as well. So just to go over, just to be very concrete about statistics here, this is published by the National Academy of Medicine, which is like the elite of the elite in academia. So one physician dies by suicide daily in the United States. That is the rate today. That is double the US population. That is, just to give it a context, that is roughly equivalent to, depending on how you slice and dice the data, the rate of individuals who die by suicide in the military with individuals with PTSD and traumatic brain injury. So obviously absolute numbers are greater in the military, but because of just the number of veterans, but the rate is the same. And this, we know, are also affecting other types of healthcare workers, including nurses. And so physician rates of depression remain alarmingly high at 40% roughly, and that's still true. I think, I'm sure the psychiatrists here in the crowd have patients who are healthcare workers, and you see a large proportion of them. It disproportionately affects women over men. It also affects marginalized populations and individuals who come from communities of color, and healthcare workers who come from communities of color as well. And then what happened in the pandemic? Well, not surprisingly, it went up, right? So we went from 40% burnout. You can see these rates here. These are average emotional exhaustion scores and depersonalization scores on the burnout scales. They went up, you can see, from 2020 to 2021. And the rates were 40% and went up to 60% post. This is just 2021 data. So this is all, these are, you know, I think what I want to just, having traveled recently to places, recently I went to India, and you know, everyone knows the stories. No one's actually tabulating them, but everyone knows the stories of how this has happened. Now the question becomes, well, did we pick the wrong people to enter the profession? Right? Maybe we just did a bad job of picking the people to come into this profession of medicine. Actually, we actually don't. We actually do a great job of picking the right people. They actually are much more resilient than their age-matched and gender-matched college graduate peers. You can see on all measures of burnout, depression, and just these scales of emotional, physical, mental health and well-being. But the predictors of those that, in this case, like when we think, what are predictors of, say, someone developing alcohol dependence? So I remember in my days at UT Southwestern, as a student, you know, you'd go through an exam, and then, like what happened after the exam? It was a massive party, you know, everyone, I mean, most students who would go, they would get, you know, inebriated, and then on to the next, right? That was sort of the, and that's not unique to UT Southwestern, that was you can ask any medical school environment, like after exam, like that is the ritual. That is the ritual of how we, quote unquote, grow off steam. But it turns out it becomes a predictor of alcohol dependence for those that are particularly have genetic susceptibilities and other life conditions. Debt is a big issue. When the average debt in the United States for a medical student is now $200,000, which is real. Some of it, you know, in this, I guess, administration did get forgiven, but still it is a real phenomenon. And then younger physicians are more prone to burnout than older ones. And as you get older, you get less and less burnout, but that's like, it's almost like, are we weeding out those that can't make it? So the ones that still going to still do it, right? So it's an interesting discussion. But it's a real, you can see that the prevalence rates are really quite high in the United States medical student populations. And these are, the reason I shared this is all of us were students at one point, and you probably encounter students at some point, or trainees or learners, or around that, whether it's in your personal or family life, or in your professional context. Over time, you know, we actually, like I said, we start off really, really good. The way we train students, though, somehow they end up worse than where they began. You can see, like, they never quite get back to where they started. And it's something about the learning environment that we have, and that's something that is real. And we see that, why do people even go to mental health care teams at their schools? The common things that commonly, again, my psychiatry colleagues say, well, this is the same list I see for any patient. The majority is depression, anxiety, adjustment disorder, attention deficit disorder, eating disorder, and substance use disorders. So students here in the United States experience intense stressors and pervasive perceived mistreatment. And as a result, they actually can't resolve the normal developmental psychosocial crisis identity, like, who am I as a provider? They don't even see it, right? The role modeling is not there. The sense of intimacy in relationships. Their lifestyle and psychosocial sacrifices. You always hear the stories, well, back in, you know, you have it so easy. Back in my day, this is what we did, X, Y, and Z, right? And so it's not, that's not really a positive message for learners to hear. They just hear like, oh, well, your life is much easier. And that's a debatable topic of whether or not their lives are truly easier. Then there's a shift to a more cynical and hedonistic orientation. So what does that mean? I sit on medical student and residency selection committees. No student writes, I'm going into medicine because I want to make money. Like, you never see that essay written. There's no personal statement you'll see out there, I'm going to make money. But somehow, there's that shift that happens, right? If we shift, we have to start thinking about the dollars and cents. No one teaches how to think about it, but it is a reality, and that it becomes contrary for many of why we entered medicine in the first place. Like, and because that type of training is not given, and all of a sudden you're forced to think about it. It's very hard, and that creates, that is attributed to now increases in depression and anxiety. And then obviously there's lack of diversity of coping strategies. So, alcohol was the most common one. And they're not good. So what happens is that it appears as if though graduating students are worse off psychosocially than when they entered as first years. And why does this have clinical consequences? Because it turns out that when you correlate burnout, you actually have increased number of cheating and dishonest. These are reported behaviors of cheating. You can imagine all the times that people have cut corners, like, oh, we don't need to do this, or but when these are reported, so you can imagine how many unreported. You can see this is a very clear linear. The scores of burnout correlate as the number of behaviors increase. So this is what many people feel, right? The job has cost me my health, my family, and my soul. Can I get a receipt? And this is a very humbling thing because all of us think, well, no, that's not me, until it becomes you, and it becomes who you identify with, and you can see this happening. And if it's not in, certainly, if you're towards the end of your career, you're seeing the sort of, okay, I see the next stage of my life, you do know that the people who are behind you are facing into this right now. There's a real clear shortage of individuals entering healthcare professions, and as many of you have probably heard through the news, it's their great resignation happening in medicine, particularly in our institution. You know, we actually can predict, if you say that today, there were 40% of individuals who, in our last survey of burnout, said that they think they might leave the field of medicine in the next 5 years. Those 40%, 25% did leave, which is a high rate when in a large organization. So it is high, it has tremendous personal and professional consequence. So how do we improve this situation? What should change? And that sort of has become, I never thought that this would be the work that I would be doing here, but here we are, like all of a sudden we have to deal with this because this is such an important, meaningful profession, has tremendous values, and people are leaving it. And so it has allowed me to think, well, then this next concept, which is about resilience. So here again, another word that you hear, and this is, to me, this is how the definition that I use. A person's ability to adapt successfully to acute stress, trauma, or more chronic forms of adversity. Resilient individuals are tested by adversity, and they continue to demonstrate adaptive, psychological, and physiologic stress responses, or psychobiological allostasis. So allostasis was a term that was coined by Dr. Bruce McEwen, and it refers to this idea, all of you learned homeostasis, but allostasis is the ability to adapt. So when a stressor is placed in front of you, you actually are able to mount that appropriate stress response. But then when that stressor is no longer there, you're able to return back to normal physiology. I was acutely reminded of that yesterday as I picked up my rental car from the airport and I drove on the highway here and I forgot my Dallas freeways, and there's all this new construction on 635 that I wasn't used to, and obviously I didn't see the merging lane. And all of a sudden, behind me was this guy just honking, and the lights were, you had to, and then I was just thinking to myself, boy, what an immense stress response did that person have for a seemingly innocuous situation, right? And so this is the thing, like, do we mount that type of stress response anytime that something happens? If you think about your own life, what is the stress response? Like, are you noticing that, are you mounting a stress response that is out of proportion to the nature of the stressor in front of you? And that's one of the key things, that when you have that disequilibrium, we see the emergence of stress-related illness. And that was alluded to in the previous presentations as well, as we think about emotional eating or sleep disruption, that when there is increased allostatic load, you're not able to maintain these adaptive, physiologic, or psychological responses. So well-being has a multifaceted definition. There's a presence of positive emotions and moods. There's the absence of negative emotions, the satisfaction with life, fulfillment, and positive functioning. But it's a dynamic concept. So if you don't have enough resources, you are burned out, right? But if you're not challenged, then you're bored, and that's not good. So there's the famous, some of you know the Yerkes-Dodson law from business, that you need to be in that sweet spot, that you have enough stress that keeps you engaged in processes like creativity and problem solving, but you don't want to be overtaxed, but you also don't want to not be able to, like, you want to actually have meaning and purpose in your life, and that's why you push yourself a little bit. Those challenges are important. And I do want to give you a very positive note. It turns out that you can be both resilient and burnt out. And physicians are the example of that. They are actually more resilient than the general population, even though you can see that as the resilience scores are higher, the levels of burnout are lower, but they are both. You can have, even though those are the highest rates of burnout, they actually still have pretty high rates of resilience. And again, they're able to adapt. When changes occur, they tend to bounce back. As compared to the overall population. So the thing that then became interesting for me in this journey is that how do we actualize this concept of mindful awareness? So how do we know where we are in the moment? And you heard, again, these earlier presentations, people talk about being in the moment. And I think in clinical practice, what I learned is, and this is the thing that I've started to work with students, residents, and my colleagues as well, is that how do you become aware of your own mental processes, listen more attentively, recognize your bias and judgments, and thereby act with principles and compassion. So it's having the ability to observe the observed while observing the observer. So what does that mean? Knowing where you are in relation to the other, knowing where you are in relation to those that you're serving. And this requires mentorship and guidance. I think the old adage was that some people are just born with this. And it turns out that it's not. These are skillful. We saw just a beautiful demonstration of our yoga practice. But these are actually skillful practices that have to be cultivated. And similarly, this is, and this article by Ron Epstein is a beautiful article in JAMA from 1999. I still use it. It's an old article, but it's an important one because it really capitulated this idea that this is something that requires mentorship and guidance. And that's the role of, as those of you, as you were thinking about in your roles as educators, teachers, mentors to the next generation, how are you providing that space of mentorship and guidance? And why is this important? Because medicine, turns out, it transforms not only the patient, but it transforms us as providers. And we see that in both positive and negative ways. And part of the reason is that meaning and values underlie our professional behavior commitment. This is the one profession we talk about meaning and values all the time. You know, we talk about professionalism, we have to talk about, you know, do you have humility, cultural humility training, do you have understanding, you know, patient satisfaction, and you have to have all these other health outcomes as well. You have to integrate professionalism into interpersonal identity. And that requires a safe learning environment. And again, as I mentioned, we have a genuine commitment to healing service. And the reality is if we don't do this now, we're never going to do this. Right? We have to do this now. This has been the imperative in my journey thus far. So what are the factors then that contribute to resilience? And this is a beautiful piece. It's a book actually written by late Stephen Southwick and Dennis Charney. And there are these 10 factors that they outlined. And I just want to state these. Each of these can be a talk in them of themselves, but the idea of optimism is the idea that there's a brighter future. Then how do we face our fears? The moral compass. All of us may have different moral compasses, but when you align with what you feel is the right thing to do, you actually feel well. And that's the key, like, do you know where your moral compass is? Spirituality, the idea of being connected to something greater than oneself. Social support, again, knowing this is, again, a sense of social support. Some of you may be seeing each other for the first time after a long time, and just noticing internally, what does that do for you? You know, I just moments before this talk, I just saw an old family friend after 20, almost 15, yeah, almost 20 years. And wow, you just feel, oh, I'm back here, here's my support. And role models. You know, who are your role models? Having physical exercise, as was pointed out, mental exercise. Developing flexibility and acceptance. How do you actually cultivate these qualities of acceptance and meaning and purpose? So where do you find your meaning and purpose? And that has actually been the greatest predictor of burnout, is when providers lose their sense of meaning and purpose in their work. And they feel like they're simply a cog in the wheel. So there's a shared responsibility here that's between the provider, institution, and society, and this has been now becoming much more public, and I think in states like Texas and that have much more sort of power to make changes across the country, I would encourage you to think about, like, how are these responsibilities shared? But at the national level, this again, the National Academy of Medicine has outlined organizational responsibilities, whether, like, for example, having a chief wellness officer, ensuring psychological safety of the clinicians. At the national level, having more federal funding, allocating funding to understand and study clinician well-being as well. But at the level of the individual, thinking about what is your own coping reserve. Like when you think about what are your negative inputs, your stress, your internal conflicts, time and energy demands, and what are your positive inputs? The psychosocial support, having social and healthy activities, mentorship, intellectual stimulation. So just want to now run through our Harvard Medical School experience. I was just before the pandemic, the dean calls me and says, we need to do a well-being curriculum. Can you do it? I'll give you a month, and unfortunately I won't have any funding for you. So I said, okay, I mean, you can't say no to the deans to do. But this is why, because Harvard Medical School got dinged on this concept that is required of all medical schools, that they actually have an effective system that promotes well-being. This is, if any of you've ever sat on one of these committees, they have to match, and this is true. This is also true. There's an ECGME in graduate that is a similar one, and now more and more you'll see it in as we look at professional organizations as well. So they developed a program, a wellness program, that was required, became required of all students, where they have to learn about healthy nutrition habits, how to stimulate creativity through the creative arts. They learn a bit about mindfulness and mental imagery. I became known as I would see them in the first week of medical school, and they would learn meditation. And so this is actually a cartoon that represents the spectrum of the different meditative approaches, right? So you have focused attention practices and open monitoring practices. Movement, and these students are quite savvy. Many of them have had already had tremendous life experiences in some of these approaches, and so you're actually learning from them more than I'm teaching them, but just having this space. And so the idea is like, how do you create space for students to engage in these things? And then we did it through a peer-to-peer coaching model, where students became their coaches for their own community, and we had these small group coaches that they would see over the year. And then we had to pivot in the pandemic, because what they were getting together in person, then all of a sudden we had to do now online. So it was a very hard, like, how do you teach meditation online? That was an unknown concept, really, especially in education, prior to the pandemic. And so we learned to pivot. And this became a way, in my role at MGH, as it was mentioned, I direct our Office for Wellbeing at our hospital. And we ended up, they said, do whatever you want, here's some time for you to do it, which was great. And so we started to pilot different. So my things was like, I want to have skill building activity, and I want to be able to create community. If we can create those two things, then we have at least created some of the fabric. Again, it's not everything, but at least starts creating some of the scaffolding. So in our hospital for the last 3 years, I've led a Monday morning meditation every Monday morning from 8 to 8:30, and it is for the entire hospital. Anyone here is welcome to attend here. I don't pay attention to who comes at this point. It's whoever comes, this comes. And then we decided it turns out that there are other people in our system that actually have experience in meditation. So why not invite their voice? So the Wednesdays became this idea to have different voices. And so every Wednesday morning now we have them. And so we have twice a week for the entire hospital community at Massachusetts General Hospital. Then we began to, and it ended up being this, it's been this, like, the president of the hospital writes it in his newsletter, Meditations with Dr. Darshan Mehta. And so it's weird to sometimes say, like, wow, I met, some of you know Massachusetts, the comical name for Massachusetts General Hospital is man's greatest hospital, MGH. And so it's interesting to see that now that they have meditations. But then we have an official TEDx talk, because it turns out there are many people like to share their story. And you can see these are just amazing stories of resilience, loss, grief, vulnerability, connection. And really found a diverse set of voices, and these are these 10-minute TED Talks that they're just meant for, like, people, what becomes to a community when they become aware of themselves? Like, oh my God, this person's in our community? And that's become an amazing space of connection. They connect with one another. And we have 26,000 employees in our hospital. These TED Talks have been viewed by at least 5,000 different individuals. So it's been, which is for a relatively small sort of endeavor, has had a really good outreach. And you can see, like, we have, this is our chief of endocrine, and he talked about his own personal and professional life, how they intersect. We have small grants for our faculty to do things on well-being. We don't know what they want, so you say, you tell us what you want. And the average request is $500. You can see that it doesn't take actually much for someone to want, but they feel like they have something here. We've tried to create try to create one space where everyone can find the resources, because it's like there's so many things out there and we don't know what we don't know. And then we have these things called Fun Fridays, where people, again, there's a physical, mental, and creative activity. So you can see there's like everything from laughter yoga, doodling, writing a haiku, chair yoga, learning about music. So these are, again, free and available for all. And then obviously being an academic environment, we want to have academic dialogue. So we've had different academic, just this past November, we had the president of the National Academy of Medicine give a talk. And I see individuals in consultations. This is separate more as a coach for them. And so it's not a clinical space, but sometimes it's a safe space for them to then know what resources that they have available in the system. And then we've done these mind-body programs as well. And this comes from my work at the Benson Henry Institute, where you have skillful practice. And these are example of it's an 8-week curriculum. It's a 90-minute or 75 to 90-minute. We have a mind-body exercise as part of it. And you can see that when we look at post outcomes, this is a scale called the Promise 29. You can see this again as a pilot, so it's not, I don't want to overstate, but you can see there's increased social engagement and participation, decreases in sleep disturbances, and decreases in fatigue. But this is what's striking. They started off at a score higher than 2, which is predictive burnout, and it ended up less than 2. And some of the comments, when people are given a space to learn skills, it turns out that people want to learn them, and they feel like it's absolutely essential. The idea that this has improved my experience of and how to react to to stressful situations, how to maintain these skills. So this is what it can feel like for some of us. Sometimes like, yeah, do this and don't do this and do this and don't do this. And so sometimes having a space, what we've done is really create space. And I think that is important. Where do you create space for some people to just breathe and try to figure out what is it I need to best take care of me? And that's been our humble attempt at doing that. Again, I don't want to discount in any way that there's structural responsibilities and systems responsibilities for well-being. And I think you can see this is the National Academy of Medicine has put out that, yeah, there's personal skills factors, but there's also societal factors, rules and regulations, organizational factors, learning and practice environment, healthcare responsibilities as well. But I think we need to be intentional in this work, and I would ask you to think about in your settings, how are you intentional? So what are you designing? You can design peer support curricula, employing, creating, providing, developing, ensuring, and training. So again, you can see that along this continuum, the idea is that how are you actively creating a space to make this a stated, explicit activity rather than something that just do it. And the more you create this culture within your office setting, the more it spills outside of your office setting as well. And we've, again, tried to do a sense of belonging, that this is, that these are a sense of inclusion and really creating diversity. Not having just one approach, but really creating diverse approaches in this. And then obviously this stuff requires investment and funding. If you don't fund it, if you just say here, it's important for you to do, but you don't give any resources behind it, then it's, you're creating like, basically you're telling someone to walk without legs. And I think that's a very difficult to ask. So this is a national priority now. And I think I want you to, this is the National Academy of Medicine's report that just came out earlier at the beginning of this year, that really, this is, we really need to sustain our health workforce because we are all wounded, and we got even more wounded through the pandemic. And it's really about, the new word is you're going to see is flourishing. And you're going to hear this word flourishing. Now I just want to just finish in my last in my last few minutes here, just talk about my own personal journey in this, because I never planned for my career to be around well-being, or for that matter, even meditation. It sort of happened in part of my own personal journey. At the time when I was going, at the time, it was about 10 years ago, we had just lost my mother-in-law at the time from idiopathic pulmonary fibrosis. And after that, we were trying to have a child, and in that process, learned that we had to go through in vitro fertilization. And those of you who've gone through it, it's a roller coaster of a journey of going through IVF, physiologically and emotionally. But we were lucky, we on our first attempt, were successful, and then we learned that we were having twins. And so we went from this low of losing a family member to this, wow, now we're having two, and there was a tremendous amount of excitement. But being a physician, when you go to each of those ultrasound appointments, you know the look on the faces, and at around week 20, there was that look from the technician, comes in, and then the obstetrician comes in and says, there's been a complication, and your twins are suffering from this condition called twin-to-twin transfusion syndrome, which is sort of one twin has more blood, the other one has less blood, so both are at risk. And there's we had to go through this placental surgery and such. And the week later, unfortunately, we lost both twins. Now, in the process, it was the first time, because I held both of the boys, they were the size of my palm of my hand. I held them in my hands at that moment. It's the moment I became a father. Like in that moment, I became a father, that you're holding your children for the first time, and you feel helpless at the same time. You can't do anything, right? As a physician, we're taught to try to do everything, and then I couldn't do anything. I think for my wife at the time, it was, there's a growing feeling of child, so her connection was growing and evolving because she would feel it every day. But for me, it was in that moment I just became and lost, and I learned what it meant to feel helpless in that moment. So we went again, we took some time to recover from that, and then had to go through the process again. And then we had our child, again, it was a complicated pregnancy for different reasons, but she was born, and our daughter Asha, which means hope, learned how to create new meaning, because for her, she will never know her older brothers in the way that we knew our sons. But she has a different view. It turns out that if those of you who have children, if a balloon is let go accidentally, a child will cry, right? It just flies off, tears out. But there's a sense of joy when you willingly let go of a balloon. If you ever see a child that they let it go, it's there's an excitement in there, and you can see, that there's this. So we had this ritual of letting go of our two balloons every February 9th. It was the birthday of our sons, and so it just taught me that I could have both grief and joy in the same moment. Why should I not have joy here as well, right? And you can see, and obviously we're in Boston, so yes, it's the thick of snow in Boston whenever this happens. But it's this, it allowed me to reclaim my sense of faith. And that led me to understand my sister-in-law and their kids. And then understanding my friends, and just again, how do we, when you think about friendship, you oftentimes in times that are tragic, we isolate ourselves. And actually it became much more important to me to reach out and say, I need some support. This is my mentor. For me, you can see in 2019, just before the pandemic, he travels the world for other things, but he had never been to India. And so him and I had to give a talk at AIMS in Rishikesh. And I had a chance to, take him to, and he's been an anchor. But then for me, it's also students. I serve as the faculty advisor for all South Asian students, medical students at Harvard Medical School. And so the learners are important. And so when we have a chance to get together. But then also my own faith. And as I think about how I reclaim my own understanding of faith, a sense of something greater than myself. and sense of belonging, right? And that's where faith, for me, has served as well. And we don't talk about faith that often in medical context. We've taught to sort of separate ourselves, but it turns out it's a very meaningful, important part. And it's different for each of us, but how we actually reclaim it is important. So this is something, as an integrative medicine and mind-body medicine, sometimes, my colleagues will feel like this with me. But I actually find this to be very meaningful for me now. This has been my gift, is to share the story. Because if I don't share the story, then others don't have a voice either. And that's the important thing. So why not? Why keep it a secret at this point in life? So, okay. Thank you to all of you.
Thank you, Darshan. Thank you for sharing your story. And something that touched me besides your personal story is we have to spend few moments to hand holding, holding each other's hand. And sometimes we forget to do that. And we are as vulnerable as our patients are. Thank you. Any questions we have? Okay, we'll entertain 2 questions. Okay?
And I think one of that.
I shall start by first making a statement and then a question. As foreigners when we came to this country, one of the biggest advantages we had is that we did not expand our lifestyle as our income went up. And I think this is something I see in today's medical students and early residents, is that unfortunately they don't even realize how the lifestyle expansion creeps up and creates financial stress and marital stress, which often plays a role in burnout. The question is have there been any studies where you looked at the behavior of the foreign-born medical graduates who were trained elsewhere and came to this country versus ones who were trained in this country in their level of burnout? I kind of have a sneaky suspicion that we who came from other cultures tend to be a lot tougher. And when it comes to resilience, we do a slightly better job, but that may be my pride talking in the reality.
Yeah. That's a good question. I don't know about studies, but I can only speak to the experiences that I've heard over time. I think the narrative of the immigration experience was always about survival. So you really came and you just did what you needed to do to survive. I think as my generation, that's not their issue. It's not survival. The question is that they have all the, especially if they're, the Indian-American community specifically is the wealthiest immigrant community in the United States. So wealth is not an issue. So they have resources. It's just now there's a lot of other pressures that are placed upon them that, again, the psychosocial crises of identity have not ever been resolved. And there's a sense of identity crisis that I'm neither here nor there. And I think that's going to be, we'll see what happens. I don't know, the story is evolving around as a generation.
Yeah, that was also one of my questions, was to see whether the stress level that you all see and the burnout, is it more, or is it the same in foreign graduates like us who come to this country versus kids that grew up here? I think the way they deal with stress is so much different than the way we deal with stress. To me, all the same about starting with the undergrad level, then going on to medical school, so much is expected out of these kids, so much of lengthy education and for nothing. I mean, all this extracurricular, do this, do that, and ace in your class, become this, become that, and you are from Harvard Medical School. Sure, that's the maximum level of stress you can get to in these students. So have you all ever figured out how to reduce the stress at that level? Maybe learn from other countries. Why do these kids need to go through 4 years of undergrad to get into medical school and top in their class and be at the level, do extracurricular, do this, do that, do scribing? What nonsense is all this? You all need to change the way you all educate these kids if you all need to get somewhere where these kids will become good can
I-
learn from the countries like India. We
Well,
all are excellent physicians, you all know that. I
So-
mean, mentally and physically, in every way. It is really, really bad. And that's all I have to say.
So I will. So I think this is a. No, I appreciate you saying that. I would argue back that I can only speak to India is what I'm most familiar with, and having close colleagues at Ames in New Delhi with the premier, right? Their problem is much worse, by the way. Okay. Because if you are a failure, there is no safety net. And I can guarantee you, if you have anyone in any medical school colleague who is a faculty member, they all know stories with students who've died by suicide in India like that. And no one talks about it because it's such a stigmatizing concept. So I actually don't think it's better in the other countries. I actually think that there's lack of dialogue, and this goes back to the issues of how do we create language around addressing this. And I think here we have an opportunity to create new language and to create new skillful practices, because some of these things are going to not just going to take change overnight. These are generational changes that are going to have to happen. So, but happy to talk more.
Thank you, Darshan. We are behind the clock.